Hi, everyone. I'm Dr. Lisa Nijam, the founder of MD Negotiation and Real World Ophthalmology, CEO of Women in Ophthalmology, and the founder and medical director at Warrenville Eye Care and LASIK. I also am an assistant clinical professor at the University of Illinois Eye and Ear Infirmary, and I'm delighted to welcome you today. We're going to be talking about meibomian gland dysfunction and lid margin disease, Imperfect, together. And I'm absolutely delighted to be joined by my dear friend and colleague, Dr. Barry Lee. He's the Cornea Fellowship Director and surgeon at Eye Consultants of Atlanta. He's also the president of the Cornea Society, and he's an expert on this topic. So I can't wait to get into discussion here. Thanks so much for joining me, Barry.
Always great to join you. Thanks for letting me come on.
Sounds wonderful. I had mentioned this in our last episode. I actually think I'm making a move for cornea to become the hottest specialty in ophthalmology because we just have so many exciting things going on, not the least of which are these new developments to help our patients that have blepharitis and meibomian gland dysfunction. And I know a few years ago, people might have not thought of this as such an exciting topic, but the truth is, the more that we learn about it, the more that we realize how much this truly affects the quality of vision our patients have, and how wonderful it is that we have new options to be able to effectively treat these patients and improve outcomes no matter what specialty you are. So, Barry, let's start talking about patients who do have blepharitis. There are a lot of different thoughts processes now about how we, differentiate anterior posterior blepharitis. How do you tell someone has MGD? So where do you start in your practice, and how do you determine the underlying cause for a patient who's coming in with blepharitis?
Sure. I think a big thing that we get a clue to right up front is we have questionnaires that patients will fill out, and that kind of tips the technicians that start working up the patients as to which avenue to go down. So I think those questionnaires have been helpful. But yeah, just getting a good patient history, I think we get a lot of stuff just from hearing what their complaints are. If I hear somebody say that my eyes are dry at the end of the day, then I'm thinking of an aqueous tear deficiency. If I hear someone say my eyes are dry, when I wake up in the morning, well, that's not a deficiency. That's probably something to do with lid margin disease or MGD. So a little bit of the symptomatology, the history, looking at questionnaires. You brought up a great point is, 30 years ago when we were treating patients with these, we would say, go home and use hot washcloths and baby shampoo and don't come back and see me. And now there's so many more. This is an explosion of different technologies that are available to us now, and even more things to come down the pipeline. So it's a great time to be in eye care in our field right now, and really some great things to do for our patients now.
Couldn't agree more. And I think what makes it so interesting and really, exciting from a treatment perspective is that we have solutions now that can be targeted to the underlying cause of some of these different disease states. And in doing so, that allows us to have more effective treatments for our patients. Just what you're saying, I totally agree. I think listening to the patient and asking specific questions, be it through a questionnaire or training your staff or even you to do it when patients come in, and also recognizing that symptoms can overlap. And so sometimes I've gotten patients myself or patients referred in that they have itching, and everybody assumes it's just allergy. And it may be allergy, but it could also be Demodex. And so now when I look carefully to examine the lid margins and looking to see if we've got signs of Demodex blepharitis there too, that can also explain some of these overlap type symptoms. Do we know what causes Demodex blepharitis? Because that's something that I know I have a lot of patients who got kind of tingly when I start explaining to them what Demodex is.
It's especially now with some direct consumer to TV marketing. You get a lot of patients coming in now and saying, "Do I have those mites that I just saw on TV in my eyes? Please tell me I don't have those." I've had a microscope for years where I would pluck lashes and look for this, and that's when it really wasn't cool to look for it. Now, patients now are so much more aware of Demodex now, and come in, like I said, they come in, ask if they have it. So I don't think we know exactly the pathogenesis of what causes it, but certainly seems to be maybe an overgrowth of Demodex, and that leads to an inflammatory reaction that causes the meibomian glands to become irritated, inflamed, getting those symptoms like you mentioned of itching or even redness. And then patients get those collarettes that are sort of the end stage where we can really tell that they have Demodex. And so it's important to listen to the symptoms, but certainly can get some patients in an end stage where it's really easy to tell they have Demodex. But I think there's some patients that are early stage that we might have to think about other clues as to whether we need to treat Demodex.
That's a really good point because I think up until a few years ago, until we really, we were in clinical trials in development of specific treatment for Demodex, which we'll get to in a moment. I don't think we paid as close enough attention to the lid margins unless there were complaints. And now that it's actually very simple, I'm sure our audience is familiar with it, but just having the patient look down and taking a look at the base of the lashes, looking for those sleeves or collarettes in even asymptomatic patients can be a sign of an overgrowth of Demodex. What sort of options were you using to treat this before, if you were treating it before, and when you pulled those lashes off and looked under the microscope, and how do you incorporate those in your practice today?
So great question. There were some lid margin kind of scrubbing devices that had some tea tree oil in them, and I would sometimes put patients on that. I don't think that the scrubs were really particularly effective at getting rid of the Demodex, but maybe they helped get rid of some of the collarettes that were on the lashes and maybe helped clean some of the scurf off of the eyelid margins. But so that's what I used to do. Obviously, there are a lot more things to add now, even from systemic therapies that have been tried. But at that point, really just either tried to use the conventional blepharitis treatments like compresses and lid scrubs, and just would try to have them find some tea tree oil lid scrubs. And we do know that tea tree oil can be effective for it, but certainly not near as effective as things like lotilaner, and that's the real kind of the best effective thing that I've seen to this point.
Yes, I feel the same way. I know there's been discussion on Caronets and other forums about using ivermectin. That's not something that I typically have used. I've tried in the past to use tea tree oil for patients. I found it to have some effective, limited effectiveness. A lot of my patients didn't like the burning and stinging that oftentimes comes with some of the stronger concentrations. And then, unfortunately, no matter how often they use it, I don't think I had any patients that seemed to be able to get rid of their Demodex completely with it, which is the exact opposite of what I have seen in my clinic with lotilaner. So do you want to, maybe for our audience, describe how lotilaner is administered, how long, give us some insight into how you've been using this in your practice?
Yeah, sure. So lotilaner is the Saturn studies. You could show that there was a significant decrease in the Demodex population. I think anywhere from like 50 to 80% reduction in the amount of Demodex eradicated by looking through the microscope to look for different lash follicles and things. So I found it to be very effective. You just sort of drop it into the eyes, and it's an effective way to get rid of it. Much more effective than the eyelid wipes that we used to use in the past with tea tree oil.
Exactly. I think what I've seen with my patients is that they seem to be pretty comfortable using it. They use it for the one treatment course twice a day for 6 weeks. And then, and I was involved with the extensions, 1 year extension study that showed that 62% of patients just needed that one treatment course, which I found to be very reassuring for patients because they can stay on task if they know that this is going to be a limited time, that they're going to have to put the drop in, that it's fairly comfortable to use, and that in a majority of cases that it's at least for a year, that may be the only time that they needed to do it. And so that's been a great addition for my practice, and particularly treating these patients, especially if I'm considering doing any type of surgery and or if they are symptomatic.
I would think it's also kind of nice to them that it's a 6 week therapy, so they kind of see an endpoint to it. Whereas with some of our dry therapies, they ask us, how long do I have to take this? And it's sort of sometimes maybe forever. So I think that there's that course that they can do really kind of makes them feel like there's an endpoint to look forward to.
Yeah, I mean, absolutely. I think as we talk with anything about lid margins, the next thing that really comes to mind and usually goes hand in hand is meibomian gland dysfunction. And we see the significant overlap between meibomian gland dysfunction and dry eye disease, and how, 86% of our dry eye patients have evaporative disease and associated with meibomian gland dysfunction. How do you determine a patient has MGD, and what is kind of your first steps or first approach with those patients to alleviate symptoms?
So I think we mentioned some of the questionnaires and things that tip us off to looking for it on the examination. But, one of the things I've added to my exam that maybe I didn't do as a resident, 25 years ago, I have a little Q-tip or a little device that I can kind of push on the glands themselves, push on the lower eyelid and try to express the glands. And I'll look to see, are those expressions turbid? I'll tell patients I'm kind of looking for oils. If a patient particularly is a big likes to cook, I'll say this is, we want the oils to be like Wesson oil, and yours are like Crisco oil when I'm pushing them out. And we need to try to get that to transition from that thicker oil back to more of a liquid phase. So I'll look at that now, and it's not always an obvious thing to see on examination. Sometimes a lid margin might look fairly normal, and then you push on it, and this Crisco type stuff comes out that you really couldn't see. There are cases where it is really obvious. You look at the glands and there are all these caps on the glands, and you can tell that they're all obstructed and clogged. Yeah. So there's varying degrees that you can see on exam, but I think just adding that to my exam technique, not just doing vial dye stainings, just looking at the slit lamp, now actually push on the glands, and that gives me a lot of information.
Yeah, I think you bring up an excellent point, because I definitely included that now in my exam. And I think it's really helpful. Well, two things. One is that I have to remember to tell my patients that I'm going to push on their eyelid, because when I don't tell them and I start pushing, they sit back. Yes. I remind myself to make sure I mention that. But then the second thing I think is, it doesn't take long, as you said, and the more patients that you do it on, including those with healthy meibomian glands, then you end up being able to identify more readily when the glands are secreting more Crisco than Wesson. And I'm going to look to see if I can get you an endorsement deal with Wesson. But I think it's important to do that, because it might not be so obvious as you said, and it may be difficult unless you start getting used to sort of assessing that for yourself at the slit lamp to identify the different degrees of obstruction.
Yeah, great points on just things to look at for the exam. And there's certainly different ways that you can do that. Whether you use a special applicator to do it or just to get a Q-tip, but I think it really gives you a lot of clinical information. And I think your point was well taken. Definitely make sure you're going to let the patients know you're kind of pushing, because you can kind of startle some of them and get them a little flustered for the exam.
And what do you do currently if you see somebody who has MGD? What is your go-to treatment, or how do you begin your stepwise treatment for that patient?
Yeah, so let's say I don't see any particular collarettes that are making me worry about something like Demodex. If I just think this is sort of garden variety meibomian gland dysfunction, I'll look for kind of other causes. Does this patient maybe have rosacea? Do they have maybe seborrhea? Is there something that's going along with this? Do they have staph blepharitis? So I'll kind of look for concurrent things. If I see somebody with like a rosiatic facial feature, which I think is a really common underdiagnosed cause of meibomian gland dysfunction, I might start them on some oral therapy with some type of a cycling agent. Minocycline is probably what I use more frequently. And then I do think it's helpful if they haven't done anything like heating. Certainly we'll try that initially, but there are so many more treatments now available for meibomian gland dysfunction that we didn't have, say 10 years ago. So things like thermal pulsation and different ways to clean off the lid margin, and different devices that you can actually use to sort of evacuate the lid margin. So I do find myself mentioning those treatment options right up front when I find a patient with it. I might start them with medical therapy first, but letting them know if this doesn't work, we're going to bring you back in like 4 to 6 weeks and probably think about doing one of those therapies, or just call my number and we'll set one of those up if you're frustrated the next week or two.
I think that's a really good approach. You did a great job there summarizing a number of the different treatments that we have. I think it's helpful for patients to have at-home therapies that they can do in conjunction with what we're offering them in the office to maximize the benefit and hopefully prolong the effect of some of these treatments. So I use all those things that you mentioned, and I found that it's usually a combination of things that seem to help patients. If you had asked me last year if I would have thought to treat potentially with lotilaner for MGD, I might have told you that I wouldn't have thought about that if I didn't see, distinct sleeves or collarettes on the eyelashes. But there's been some recent data that I think has spoken to the potential for lotilaner to help with that too. There's a study about TP03 that showed statistical significant and clinically meaningful improvements compared to baseline in the presence and quality of liquid secretion as measured by the Meibomian gland secretion score and the number of glands secreting normal liquid in the central 15 glands of the lower eyelid. And so I think it's interesting to think about. There was actually also a case report in ophthalmology earlier this year from China with a patient, a middle-aged man who had been complaining of dry eye symptoms, and they had tried some conventional therapies. It did not improve. They actually went searching for Demodex, and when they had expressed a gland, they had about 15 Demodex brevis that popped out. And so they were making the case for, even though, we think of these sleeves as pathognomonic of Demodex, but that you might actually have some underlying Demodex. And I wonder if that also may be sometimes some of the underlying cause of MGD.
Yeah, I think that's a great point, and that does sort of underscore the importance of, you're going to catch some of these patients early in disease. Not everybody's going to be at the end stage where you catch them and it's easy to tell. All diseases have a variation of mild to moderate to severe, and you're definitely going to be catching some patients in a more milder form. And so I think for that reason, it's really important to keep in mind of those different adjuncts. Yeah, I think even we mentioned rosacea earlier. I think rosacea patients really probably have we know have a high colonization of Demodex, not only in their face, but in the Meibomian glands. And that's a particular case where, I think lotilaner is a good addition for someone that you're diagnosing with ocular rosacea, to really keep that in mind. And we certainly have oral agents that we use to treat the antibiotic parts of this. And the dermatologists have facial creams and things that they can use. But I think this is a particular treatment that we've probably underutilized in the past and didn't really know a lot about or think a lot about, that I think we could really help patients out with.
I completely agree. And I want to, just for our listeners, can you give us a quick recap on rosacea signs that they should be looking for, either alone or in association with this? Because your point is very well taken. Ocular rosacea is often undiagnosed and definitely underdiagnosed in general, and especially in this population.
So even just entering the room, a lot of times with the lights on, I can look at patients and just look at their facial features and see someone that's maybe fair complected, red hair, blonde hair. You can see some facial flushing of their cheeks and nose. Some of the men have that rhinophyma where their nose is kind of enlarged from the rosacea. So those are some pretty easy things that you can just easily looking at the patient can maybe give you a clue. But then when you look at the slit lamp, you're going to see some really marked eyelid telangiectasias. You really shouldn't see marked telangiectasias on a lid margin that's not inflamed. So that's a dead giveaway. A lot of times they've got these capped Meibomian glands. They might have a lot of higher amount of scurf on the lid margins, which is owing to that clogging of the glands. And then, like I mentioned earlier, taking a Q-tip, these are going to be the patients that you push on the eyelids and get this thicker secretion. Sometimes it's even, instead of it being a clear secretion, it's sometimes an orangish color with some of the rosacea patients. And so those are some things that you can look at just gleaning from the slit lamp examination. But I think just walking into the room, I can kind of get an idea. If I've already looked at the history and I see their facial features, I can already get a little bit of a targeted focus when I do the eye exam.
Yeah, those are excellent points and things I think definitely for our audience to keep in mind when you're looking at your patients to recognize that the skin manifestation does really cause problems with the eye, has high association with blepharitis, with Demodex, and with meibomian gland dysfunction, and something that we can all probably do a better job of identifying sooner. And then again, we'll be looking for more data on lotilaner in conjunction with treatment for MGD. But we also know that there is AZR MD001, which is a selenium sulfide ophthalmic ointment that is in the pipeline coming for treatment of MGD. And Barry, do you want to tell us a little bit about the Astro trial that just got started with that?
Yeah, so the AZRMD001 is a selenium sulfide solution. I think probably many people are aware of selenium sulfide in certain shampoos that patients have used for dandruff or oily scalps for a number of years. And that's sort of taking along that lines of seeing that that's a good treatment for MGD. The cool thing about this medication is it's sort of a twice weekly application. So it's not something you have to do every day. And this was a medication that you could just clean your hands and wipe onto the eyelids. And I know at least from the participants, this was a randomized assigned trial 1-to-1 ratio with the AZRMD001 or the vehicle with follow-up visits on day 14 and then months 1, 5, 3, 4, 5, 6, 9, and 12 months. So it's a pretty interesting and robust data going out to a year. I do believe they're enrolling in phase 3 trials now, so it's not something you can get your hands on unless you're in one of the study sites. But I do think the compliance of this will be nice because it's just a twice weekly thing versus having to do something on a daily basis. So it'll be interesting to see how the phase 3 studies pan out.
Yeah, I completely agree. I mean, I've worked with them and see that the results from phase 2 have been quite promising, and it's something again that's exciting in the pipeline, and assuming that the phase 3 data mirrors that, it's going to be a really excellent addition to the armamentarium that we have. And I also look forward to seeing more on lotilaner for MGD. What they've done with these initial studies showed significant increase from baseline in the meibomian gland secretion score and the mean number of meibomian glands secreting clear liquid from baseline. So it's exciting to have new data and as well as new pipeline products that potentially can help these patients suffering from meibomian gland dysfunction and the resultant consequences that come with that. I think now is a good time to wrap up our discussion here. Dr. Lee, do you have any final thoughts you want to share?
I think it's been a great session, and just keeping in mind that this is a very common problem that you're going to see in your practice. So really be on the lookout for it. Try to pick up patients that you can hone in on knowing where to go right when you start up with working them up. And we can really help patients out by helping this very common problem. And it can be a nuisance for work-life balance for a number of patients.
It's really important to keep in mind. I think it's one of the things that continues to motivate us to keep elevating the level of care that we provide for our patients and utilizing this entire spectrum of new treatments for our patients to personalize care and to improve their daily function. I think that's such an important point that you brought up. These are things that we might have dismissed a little bit more readily in the past because we didn't have such specialized treatments. But these are very common problems, and these are things that really bother our patients and hinder them having the best visual outcomes that they can have from surgery, as well as the best visual outcome on their day-to-day in their day-to-day lives. So I just want to thank you so much, Barry, for this excellent discussion. Thanks to our audience for listening. Please remember to take the post test and complete the evaluation to receive your CE credits. And please tune in next time for additional episodes within this exciting series in the hottest specialty. I'm going to say it till everyone believes it with cornea and everything else. Thanks again, Dr. Lee, for joining us.